Yeah, we can sit here also.
So hello everyone. Welcome to another seminar series organized at NetC London. Today we have the honor to receive Simon Lindner. For those who know, Simon is a complexity science researcher specializing in general medicine and data-driven epidemiology. He is nowadays completing doctoral studies in the Medical University at Vienna and at the Complexity Science Hub of Vienna, where his research focuses on analyzing large-scale health data to uncover sex and gender-specific differences in chronic diseases and health outcomes. He has contributed to international and to several collaborative research on cardiovascular health, privacy-preserving data sharing methods, and wastewater-based epidemiological surveillance. We are very excited also to receive Simon because there is a high probability that he's going to join the Brand Lab in the future. And without further delays, Simon, the stage is yours.
Okay, I started person. Yeah, let me. I know this is fun. Just need to put prominence on this.
Okay. Thank you all for being here. I know the talk says something different, but I wanted to start with just introducing a little bit of the projects that I did during my PhD, because I have the feeling like my projects are all over the place, and it was actually very hard for me while writing my thesis to have like a thread that goes through and connecting all of it. So a thing that I worked a lot on was comorbidity networks and also the role that socioeconomic variables and gender played in it. This is one paper we published during my PhD. And there we looked at people with hypertension and how the socioeconomic variables like employment status, education, also household size and marital status influenced the interplay between hypertension and these other chronic diseases. So what we found there is that, not very surprisingly, men and women are affected differently by the socioeconomic factors. Here we just see that for some of them, like there's an effect on women or there's only an effect on men, which is significant. And for the black lines, we had a significant gender difference between men and women. So usually, so the thing we found is always that the performance or the odds ratios for women were way worse than for men if there was a significant difference. So all these factors just had a negative influence on women regarding these chronic diseases. The second thing I worked on, we just released this paper just like a few weeks ago, but it's still COVID related. It was like in the pipelines for a very long time. And we looked at wastewater data. So we had disease in the wastewater, virus particles in the wastewater. The virus is only in the feces, not in the urine. This is why we have the toilet here. And then we connected it to the number of conducted tests. So with the increased number of tests, so it's not as likely to find more diseases. So if you have to double the amount of tests, of course, you won't find like double the positive rates. But the rates will increase with the tests. And so we have a power law relationship here. And we use this to then use the factor we got out of this regression model to put on top of the reported case numbers. So we could get an estimate for the unreported case number. And yeah, this was very recent work we did, just published it. I think it was kind of nice to work with, because like the problem here was to combine all the wastewater data. It was a lot of wastewater treatment plants. A lot of them, we had a lot of different laboratories. that were analyzing this data. So there was a variety in this, and this were like the challenges in this work. Another thing I worked on was opinion dynamics. And here we had a model where we had an icing model. And so when you think about the spins as people, so people were able to form groups. And so it's like it's like when you're in this group, then there is a pressure on you that you change your opinion and you change like according to all the other people in the group. And or you could just switch the group to reduce stress on the system. So we have one thing that you could just switch the group, or that you align with all the other people in the group. And this we could solve analytically, and and also had like a Monte Carlo simulation confirming our results. And we also used this then to data from online game where people could chat with each other. And with this model, we could predict the average group size in this data. So this is a Pardos data. This is like a space online game where people could form alliances, communicate with each other. It was used on quite a lot of this research. And for our model, the average group size fitted kind of like perfectly with the data here. So now I'm getting to the main part of the talk, talking about the cancer patients' trajectories. And so the motivation for this was kind of, there are two waves so far for cancer patients stratification. The first was with histopathology. So images of the tumors. Here we see the tumor here. And here we also see the tumor cells here. So this was the first way to categorize or look inside the body and know more about cancer. And with the second wave, there came all the biomarkers. So proteins you can find in blood, in the urine, in bile, and this was the next thing that was used for diagnosing cancer and finding out more stuff about cancer. And our motivation was to kind of like introduce like maybe a third wave and getting like the socioeconomic status again, also mental health information we had about the patients, and the treatment routes and healthcare trajectories. So the visiting patterns of these patients to further find information about these networks. So the data we used, we had quite a long time span for the data set. It started in 1985 and it's till 2022. And we had 8,000 patients diagnosed with different forms of cancer. And for all of them, we had a questionnaire at the beginning of the treatment where they were asked about their pain, so there were questions about their mental state. So we have a depression score, we have an anxiety score, we have a general questionnaire about fatigue. We know like the socioeconomic status of them. And we also have then the visiting patterns of all of them. So every hospital visit is in there with the diagnosis the main diagnosis they got during that visit. So this is the sequence length distribution of all those visits. So of course, like a lot of them are very short. So we just have like a few stays we cut them off, and like we're only considering like the 90% percentile of the longest, so the longest and the shortest trajectories we cut out. And and then we try to find some information about so then we try to compare the trajectories against each other. So what we then defined is this metric. So the distance here, so we define distances between trajectories. So the distance here, this is an outpatient admission. These are two patients, two trajectories. And if both of them have the same thing at the same place, of course, like the distance is 0. And here, for example, then we have an inpatient hospitalization and a break. The break we put in when we had no hospital visit in a certain period of time. And if this is different, we define the distance as 1. But then for all the visits where we had a very common diagnosis, we use the ICD-10 codes. So the ICD-10 codes are very detailed. They define like a certain, so like all diagnoses you can get in a hospital. And this, for example, is breast cancer up here. And this is peritonitis. These were 2 of the most common diagnoses we had in the data set. And for the distance here, we defined it as 1 minus the co-occurrence rate of these 2. So with defining those distances between the patients, we then used dynamic time warping. So does this? Yeah. And dynamic time warping is mostly used for signal processing because like the signals can be shifted against each other. It's not only giving like a point-to-point distance, but it can also be shifted a little bit to the right or to left. And also one event can be, the distance from one event can be mapped to multiple events of the second trajectory. So here you have these 2 examples. When they are shifting against each other, here, for example, that's 1 point is then connected to 4 other points. So you're trying to minimize the distance between 2 trajectories, and you shift them against each other, and and minimize it, and also allow it to have the same, use the same point multiple times. So this is, for example, when you compare speech against each other, you might say the same thing, but you say it like faster or in a different pitch, and this is a method that's kind of correct. Then we had like the distance matrix between all our patients, and we used hierarchical clustering to identify nine meaningful clusters. And then, of course, like the question was, do these clusters have any meaning, or are we just reproducing like certain diagnoses or certain socioeconomic status? So like all the women fall in one cluster, then there's a male cluster, then there's a breast cancer cluster. And so the question was, are these clusters actually meaningful, or are they just reproducing something trivial? And so what is the and also, do they have any explanatory power? So is there a difference in survival rate in different clusters? Also, if the clusters are connected to mental health in any way, do we have like a pain cluster? So where all like the patients that have a very high pain score fall in clusters 3, or if there is like all these multiple examples, and also like which information is actually then contained in these clusters. Here, just for example, how these clusters look like. We have like the transition probabilities between the different ICD-10 codes. So these are the different diagnoses. Then we have this additional events like the hospitalization, which is here, the S. And then if they die during, or die at some point, then this is also an event. The thickness of the lines is like the probability of going there. For the death, this is like not on the same scale, because otherwise this would be just invisible, but it's a very significant event. And here again, we have also the break event where we don't have data for a very. And this is a little bit of a description about these clusters. So all of the scores we have in the beginning, and it's ergonomics. So we have this pain score. Sex-wise, like all the clusters are nearly the same. So they are both like 50% females, 50% males. Also in the pain score, we don't see like a big difference in the clusters. Only like cluster 5 and cluster 9 are a little bit different. And only in for the death chance, the cluster 1 is like the same as the cluster where there are the least deaths, and then cluster 4, 5, and 6 and 7 to a certain extent are the high-risk clusters. Also for the depression score and for the anxiety score, we found a little bit that some clusters were outlying, but they're also very similar. And then we put like this information about the clusters with age, the socioeconomics, also the sequence length, and all the diagnoses that patients collected during their stays into a regression model. And here we have very significant effects for the deaths in different clusters. So also here the cluster 1 is the reference. So for example, like in cluster 2, we have odds ratio about like 1.8. So 1.8 higher death chance in this cluster than in cluster 1. We also looked at the anxiety category and the depression score and compared it from the clusters. Here the results are not that significant. We are always around 1, but it's also a very different perspective, because here we're not really looking at the outcomes, but it's something we measured in the beginning of the treatment of these patients. So in general, I would say we kind of succeeded in this sense that we found that there is some meaningful information in these clusters and in the healthcare trajectories. And further steps would be to find out what exactly is it about this visiting trajectories that's making this impact. And yeah, there's a lot of further research that we can do in this regard. So at the end, I'm also like talking about what's the plan to do at Northeastern. So at the scholarship we are applying right now. And so the motivation here is mental health is a dynamic thing and it changes over time, and it's mostly expressed about speech, or like how people express it, talk about it. And most of the research is static so far, and the idea is to see in like dynamical speech patterns changing over time if we can find meaningful changes and expressions that we can. So the data that we have here is the transcripts of therapy sessions, which are conducted in Portuguese. Unfortunately, I don't speak Portuguese, but
yes.
And per patient, we have 60 sessions. And over the course of the sessions, they're also reporting on their mental state. So how are they feeling? How are they improving? Or so we kind of know how they talk about themselves, how they're expressing themselves, and also how they report about their feelings and about their general well-being. And also in data, there are 2 therapy types. The one is cognitive behavioral therapy, which is one of the most common therapy types, and usually also like the most effective in most studies. And the second one is the emotion-focused therapy. So from my knowledge so far is that comparing all of these 2 types against each other, cognitive behavioral therapy usually works very good, and emotional focused therapy can work better in certain cases, and it's like the only contender so far that can have the same effect as cognitive behavior therapy. Yeah. So what can we do with the data that kind of would predict or help us in determining the health state and how it develops over time? So we want to see if there are any signals in speech networks, in language networks, that we can then, where we can see, okay, there is a shift in the well-being after we see this and that change in the networks. This would be one thing. Or also like the same thing we did with the cancer patients. Is there some way we can cluster them, reduce this information down in the sense that we can use it then to talk about these patients? Also, like, since we have these two therapy types, is there a difference in how people are talking? Like, is there a difference in the two therapy types? So, do we see different networks? Is there like a different response mechanism? These are all things that we can do here. The two types of networks we're going to use is on the one side, the co-occurrence network. This is from previous work from Sophia about this suicide letters. So the co-occurrence here would be is stepwise. So if I need to go now, like there's a connection between I need, between need and to, between to and go, and between go and now. And the other network type would be the subject-verb-object networks, where it's the sentence gets broken down into the structure, and then the edges would be between I go, I now, and go now. So with the co-occurrence network, like the words can then be categorized into positive emotional, negative emotional, or neutral. And then we can do like stability analysis, so stable and unstable triangles. So in this thing, like all positive, and the edge would be positive if both the nodes are positive, negative if one of the nodes is negative, or both of the nodes are negative, like here. So this tells us that all of these triangles are possible except this one, because we can't have like one negative node and two positive nodes when we are using this methodology. And then we get from the co-occurrence networks, we get like a ratio between positive and negative triangles, which then could be further used to put in the model that then can predict outcome. So we're trying to get like the language networks, also then like other patient characteristics we have. Socioeconomic status would probably has an influence on how the outcome of a therapy would go, and also patient's characteristics. So again, gender or /sex, since most of the time it's just like a sex variable and we don't have any idea about the gender actually. Age, and then we get a lot of like variables that we can further use to make a classification and a prediction. Okay, thank you very much. This was very fast, but I'm gonna need more time. But I'm very happy for questions.
Simon, very interesting talk. So now we have around 10 minutes to make questions. So please go ahead. Anyone has any question to ask Simon? Sophie.
Thank you so much for the presentation. It was really interesting. I have a question about the clustering that you did in the cancer patients. Could you elaborate in terms of like what, if you try to like identify who or what kind of people or trajectories are within each cluster? So basically, I understand that you have the different clusters and you see some differences according to, I don't know, like pain level and depression or death. But who are in the clusters? And I think also who are in like cluster 5, because if they seem to die, but they have the nicest death among them. They don't have pain, they're not anxious.
Yeah, but this is with the pain and with the anxiety is also the problem that this was in the beginning. We couldn't like, because we tried to then like find something trivial to explain the clusters. Also, this is not on there, but also what I tried was like looking at sequence length. So maybe just like people who are takes way longer for them to get better. So maybe just the sequence length is determining the cluster. But it's not so, we didn't really find like a trivial thing that you could say, okay, this cluster is that, this is the information that's in there. So this is really, I mean, either we didn't find it, or this is really like the information that's inside of these trajectories and really in the pattern, in the visiting pattern, that's determining the cluster. And there is some information there. So this is like the big question, what is this cluster exactly? And why has this predictive power for death? And what classifies it? So this is the further research thing.
Haley, as
I
well.
also have a question about the clusters. I think it's either the next slide or the one after, but I was curious, yes, back. Yes, what motivated the use of cluster one as your reference cluster for your statistical tests?
Just the first cluster.
Okay. I didn't know if there was something about like, oh, they're less likely to die and we want that to be the.
No, it was, I mean, we could have just like, I mean, it's a regression model, so in this, for the significance, it doesn't really make a difference what is the reference category. We would just like shift it all. I mean, also like cluster one is the one with the lowest death rate, so we then see like the increased, so everything is above one. Otherwise, it would be the other side around. So we would have like a high death cluster as a reference, and all the other clusters would have higher survival chances. So yeah, but there's not like a specific reason why it's cluster one. And it is.
Yeah, I have two questions. The first one is very straightforward. Can you come back one slide? So here, the heat map, the normalized mean value per cluster compared to the remaining cluster. What does it mean compared to the remaining cluster?
So like you pick out one cluster and then look at the remaining cluster. So we take it out of the so okay, for example, like we take out PTSD from cluster one and then compare it, is it higher like from all the other clusters together? So cluster one, people in cluster one are taken out.
Okay. And that's why it's like not just between 0 and 1, so it cannot go over because of comparing with the other cluster. Okay, I understand. And the other question is about like what you might work here. So you were saying about like when you are analyzing the like the sentences, for example, you mentioned, okay, I have two ways to do it. Either I connect them just word by word, or like if it's like subject, verb, object. And then you said like once you have these connections, then you can assign like a positive or negative.
Yeah, this is
So how would you do it? Like how does this work? Like go the next one. So yes, here. So then this concurrence is just. So how do you do this? Like is something like inherent of what is in the word, or just like how do you construct these signs?
what is in the word? So
I don't know, like
hope would be, for example, like positive.
yeah. So these balances, where do they come from?
Yeah.
Like they are from like a sentence. For example, if you have a sentence, then this sentence will like have a specific balance of this category.
Okay, yeah, the notes here. So the notes here are words. And if they co-occur, there's a link.
Okay, and then
The link is positive if both words are positive. So if we have happy and hope, for example.
and then if one of them is negative,
If one of them is negative, then the link is negative.
and also if both of them are negative.
Yeah.
Okay.
This is why this doesn't work, because if one of them would be negative, then if just one node is negative, then two links would be negative. And then we cannot have like a triangle with two positive things and one negative.
And where does this like kind of like positive negative value come from? Like they're like I don't know, like where does it classify?
Sentimental analysis. So comparing it to a dictionary, and then, as I said, like classifying them, like happy is positive, fear is negative.
Okay.
Rush?
I guess similar on that same note, how would you associate words that have positive meaning if they're like there's one negative word and one like I need to go so bad, like you want to go to some concert or some event so bad, but you have the word bad in the context of like urgency, but it's so how does sentiment analysis work with that? Because usually it just assigns a +1, -1, or 0, right? So
yeah, that's a problem. No, this is definitely something that we have to look into and maybe correct for. I don't know how significant it is, but I mean, this is a general NLP problem that some words have multiple meanings and it's very dependent on context, get the meaning out.
But is there any way to like associate, like embed the, I guess the context with respect in this kind of framework? 'Cause in this way, you're just associating with in words, right? So
Not like with the easy way, but of course, like in an with easy LLM models. I mean, the problem here is also that we don't. I mean, this is very sensitive data. We cannot just upload it to ChatGPT and ask him to give us sentiment analysis on this. So everything we're gonna do with this must be hosted and sandboxed. But also like easy LLM models could maybe solve this. But the question is, what is possible like in a sandboxed, contained environment?
Okay.
And then,
It's kind of adding on to that. Is there a reason, because this is like kind of a networked approach, right? But then we have NLP models that are perhaps more and more outdated and not LLMs, but that do capture context and have like sliding windows so that you can kind of understand then if it's being brought up in like a negative tone, even if it's like a positive word. Is there a reason why kind of you're leaning towards a more networked approach and like maybe something you can capture some certain aspects of it from there, like of the.
I mean, one reason is just like it's simpler, it's maybe easier to understand. And also, I mean, also for the co-occurrence networks, the plan is to do this with sliding windows. So to have like a certain context in there, not really context, but an environment where this counts. And we are also completely, I mean, this project is also then evolving. This would be like the first approach or also what is in the proposal. But it isn't said that we will use any more advanced methods at some point. Explore different methods.
actually, I have one question, but it's not closely related with the main topics that you described now. It's about your previous research in your PhD. You were talking about how spins change of groups. And I would like to ask you if you could explain again what mechanisms deal to the change of spins when they change of group, basically.
So
Because you said that, so you have one spin then, and the spin can change within the group or it can change of group, right?
Yeah.
And I want to ask you if you studied like other mechanisms that explain why these spins change within groups.
I mean, this is maybe I just talk about this project a little bit more. So this was motivated by so it comes more from the thermodynamic side, and then like the opinion dynamics was more the application of this. And we were coming from a place where we were interested in systems that where the phase space grows faster than exponential, and you can't use then the classic statistical physics approaches. And then we had this magnetic coin model where they just flip from so you have a spin model where they can have two states, and then they have one state where they stick together. And this was done the work we had after that, where we had like not only the sticking together phase, but in general like this group formation thing. And we were able to solve it. And I think this opinion dynamics it's more like a mathematical model, because just the model is nice and we could solve it. And then we were looking for applications like.
Oh, so you didn't apply in the real data in the real data sets.
We applied it, but this is whoops. This is a little bit. I mean, we had discussions about this because I'm also not sure that this is the right data to apply this to.
Okay.
But there it's messaging networks. So people who are chatting with each other, and then if you're chatting with the other person, then you are also in this cluster. So then you have, for example, like this very small networks where just two people are chatting with each other. Then you have like networks where three people, or there's one central node, one person is writing with him, with them. and another person is running with them. And that's the cluster. The only thing that was reproducible was that they had the same group size as our model predicted. So I think like the changing groups or flipping opinion thing is more like when you think about friend groups. I mean, we always talked about like political situation in the US. You're Republican or you're a Democrat. If all your friends are Republicans, you either become a Republican or you find new friends. That's the most likely thing. And I mean, mostly it is that you just change your mind and not that you look for a new social circle. But this would be like the two possibilities if you stay in this picture, what this model allows you to do.
Anyone else has questions? Okay, so I think we can finish our seminar. Thank you again, Simo. And now let's go to a pub.